So when these heart valves open closes, they contribute to heart sounds too, right? When we auscultate the patient's heart, when we listen to the patient's heart with a stethoscope, and usually there's two sounds, right? Lub dub. Remember in your class, lub dub, lub dub. Lub is the first sound. Dub is the second heart sound, right? And during the lub, what happens that is when your atrioventricular valve closes, and dub is when your semilunar valve closes. So what happens when the first heart sound, lub, when your atrioventricular valve closes? What happens? That means your ventricle is pumping, right? The right side of the ventricle is pumping deoxygenated blood into your lungs. The left side of the ventricle is pumping your oxygenated blood into your systemic circulation to the rest of your body, right? And the second heart sound, dub, what happens? This means your semilunar valve is closing. So when the semilunar valve closes, that means your heart is ready to dilate, right? Your heart is ready to receive blood. The right side of the heart receives deoxygenated blood from your right atrium, while the left ventricle receives oxygenated blood from your left atrium, right? So lub dub, and so lub dub is when when your valve closed, lub, atrioventricular valve closed, dub, your semilunar valve closed. And sometime we're gonna hear a third heart sound, so lub, dub, and a third heart sound, like a murmur or something. And this could be normal, or it could be pathological, something that we need to investigate further. So what kind of sound, what kind of murmur could it be? Like, what could cause murmur? Anything that causes turbulent flow. It could be, as I said, it could be pathological, or it could be normal. A few review video ago, I talked about pericarditis, how the cover of the heart can be inflamed, and that can cause like friction rub, and that could be a murmur. We can hear that. In addition to the lub dub, and we can hear like a friction rub. So that's the third heart sound. Another example of third heart sound that we can hear is from something that we call the valve stenosis. Stenosis just simply mean like a thickening of the heart valve. It can happen to any valve. It can be calcification or anything like that, and that's called valve stenosis. So it'll cause like a turbulent blood flow when the blood flows through the valve, and that could be like a third heart sound. It could be a murmur. Another example is regurgitation, right? A valve regurgitation. So that's when the heart pumps, the blood moves backwards instead of going forward. Let's say there's a mitral. Let's say there's a mitral valve regurgitation. So when the heart pumps, instead of the blood going up through your aorta and through your systemic circulation, some blood's going to move back into your left atrium, right? So that's regurgitation, and we can hear that. We can hear that too. Another murmur is when, let's say there's a hole between the left side of the heart and the right side of the heart. There's a hole, and the blood can move through between left side of the heart and right side of the heart. And usually we see this during something we call ventricular septal defects. So we could hear the blood flow. We can hear the blood flow through the whole of the heart too. And when we hear a murmur, we're usually going to do an EKG on the patient, and we can do an echocardiogram to see the structure of the patient's heart, to see the defect, and to see if we need to correct the defect or not. And usually I have to mention that the tricuspid valve, usually you don't see too many defects. If there's a defect, it's a congenital defect or anything secondary to the patient being an IV drug user. So an IV drug user could have endocarditis, which may cause tricuspid regurgitation. You may see that. And for those of you who forget what endocarditis is, endocarditis is the inflammation of your endocardium, and of course the endocardium is the muscle layer inside inside the chamber of your heart, right? That's the endocardium. So the endocarditis is the inflammation of your endocardium, and one of the cause of endocarditis is of course bacterial infection. Now back to the tricuspid valve a little bit. So why does the IV drug user more prone to having tricuspid valvular disease than any other valve in the heart? Well, imagine this. Usually IV drug user, they reuse the needle, right? And that's going to be some bacteria on the needle. Usually Staphylococcus aureus or something like that will be on the needle. And when the patient injects themselves with the blood, that bacteria will go into that bloodstream too. And that bacteria in the bloodstream will make its way eventually back to the heart, right? And which valve would the bacteria pass first? The bacteria would pass through the tricuspid valve first, right? The valve between the left atrium and the left ventricle. So that's the first valve. So the bacteria will pass through that valve first, and they will be able to deposit and colonize onto the endocardium and onto the tricuspid valve itself, causing inflammation and infection and endocarditis. And you may wonder why the bacteria from the IV drug user, why is it less likely to cause any valvular disease on the left side of the heart, say the mitral valve? Why is that? Well, you have to imagine that the left side of the heart is more high pressure, right? The blood flow through the left side of the heart with high pressure, there's more turbulent blood flow. And more turbulent blood flow in high pressure environment, that makes it very hard for the bacteria to deposit onto the endocardium. Makes it hard for the bacteria to colonize onto the valve on the left side. But on the right side, the bacteria will reach the tricuspid valve first, and the bacteria will have time to deposit onto the endocardium and cause infection, cause inflammation, and cause endocarditis, which the bacteria on the valve of the tricuspid valve, it can cause damage to the structure called a tendon to the cords. So that will cause a problem of tricuspid regurgitation when there is ventricular systole and stenosis. And mitral valve stenosis is a thickening or the narrowing of the mitral valve, right? So there's going to be some trouble filling the left ventricle during ventricular diastole because the valve is narrowed. Mitral valve is narrowed. So what can we see? So with the mitral valve stenosis, the blood may be backing up into your lungs. So you might see pulmonary edema. So you're going to see patient maybe having shortness of breath and things like that. You're going to see patient feeling fatigue, weakness, tiredness, and that's simply because, again, the blood is not flowing to the left ventricle with the right amount, and that amount is less than usual. That's the left ventricle is pumping out to the rest of the body, and the rest of the body is not receiving the usual amount of oxygenated blood. So that's going to cause weakness because your brain, your tissue, your organs not getting enough oxygen as it should. So that's the reason the patient should feel fatigued and tired and things like that. And also the cause, normal aging, the mitral valve will narrow because of calcification build up when you age. And also another thing is that it's common for mitral valve stenosis that you might see on the test is rheumatic fever. Rheumatic fever will cause your mitral valve to thicken. But in the United States, normally we don't see rheumatic fever much anymore. So if they want to test rheumatic fever and mitral valve stenosis, you should look in the question stem. The question stem should mention that the patient is a foreign patient, or maybe they'll say something like the patient is an exchange student from overseas or something like that, and then you can think about rheumatic fever as one of the answer choice. Also, they might test something about stroke and cerebral embolism with mitral valve stenosis. So basically, with the mitral valve stenosis, with the thickening of the mitral valve, a blood clot may break off and travel through the left ventricle and onto the aorta and into the carotid and into your brain. Regurgitation or aortic valve insufficiency. And what is that? That is when your aortic valve doesn't close tight enough and there's a leakage. So your left ventricle will pump the oxygenated blood from your left ventricle to your aorta and to the rest of your body. But that's but the valve, the aortic valve, doesn't close tight enough, and that blood will leak back. That blood will leak back from the aorta into your left ventricle, especially during ventricular diastole, when the heart dilates, and the blood from the aorta shouldn't be coming back to your left ventricle. It should be going out to your systemic circulation. But if there's if the valve is insufficient, if the valve doesn't close tight enough, there could be a leakage, and the blood that's supposed to go out to the rest of your body can leak back into your left ventricle. And what kind of symptoms can you see with that? You can see the patient being tired, fatigue, and you can see cyanosis also. So why do these symptoms occur? Why do you see these symptoms? Because simply, if the blood is leaking back, if the oxygenated blood that's supposed to be going out to the rest of your body is leaking back into your left ventricle, you're losing cardiac output, right? And that blood, that oxygenated blood that's supposed to be going to the rest of your body with oxygen and everything, it's not going out there enough. And some part of your body, such as your brain, your tissue, your organ, is not getting enough oxygen in that oxygenated blood, because that blood is leaking back into your left atrium. So it's not going to your brain, it's not going to your tissue. So you're losing cardiac output, you're losing oxygenated blood. So that's why there's some symptom of tired, fatigue, and even cyanosis, because you're losing cardiac output with aortic regurgitation. The patient may be shortness of breath, and a good physical sign of aortic regurgitation is head bobbing. Head bobbing with bounding forceful pulse. And this is a good telltale sign on the test. When you see these words on the test, you should be thinking about aortic regurgitation. Is patient having physical sign of head bobbing, and forceful bounding pulse. Why does that happen? Why does the head bobbing happen? Well, imagine this: the left ventricle is pumping the oxygenated blood up the aorta, through the carotid, and through the rest of the body, right? And when the blood reaches your carotid, and the blood leaks back into your heart, so the blood goes up the carotid and then comes down. So the blood goes up to the carotid and then a little bit comes down back to your left ventricle. So when the blood goes up and down the carotid, your head bobs. Your head bobs like that. So that's a physical sign of head bobbing, because the blood, your optic nerve or your cranial nerve 2 is involved with your afferent limb of your pupillary light reflex, and your cranial nerve 3, the oculomotor, is involved with afferent limb of your pupillary light reflex. What does that mean? The afferent limb of the pupillary light reflex basically means that your eye is sensing so much light. It's just like sensing so much light that's coming into your eye, and your cranial nerve 2 is telling your brain there's a lot of light, right? So afferent limb, it's kind of like being telling your brain that a lot of light is coming through, and efferent limb, it's kind of like a reaction. Usually, it'll be a motor reaction. So so basically, cranial nerve 3 is involved with efferent limb. So that's a reaction, right? Cranial nerve 2 basically is saying a lot of light is coming through. Cranial nerve 3 is basically saying that, okay, we understand now a lot of light is coming through, so we're going to send a signal back to your pupil to constrict. So basically, cranial nerve 2, which is the optic nerve, will tell the brain a lot of light is coming through, and then cranial nerve 3 will make a response of making your pupil constrict. So cranial nerve 3 will be involved with the motor reaction on your lab exam. So what structures passes through the superior orbital fissure? That's 9 of them. So 9 structure passes through the very little hole, and you have to know them, right? So you have the frontal nerve, you have your lacrimal nerve, and you have your nasociliary nerve. These 3 nerves are actually branches of your trigeminal nerve. These 3 nerves are V1, branches from the V1 of your trigeminal nerve. So frontal, nasociliary, and your lacrimal nerve. And next you have your trochlear nerve, cranial nerve 4. You have abducens nerve, cranial nerve 6. And you have your cranial nerve 3, but you have 2 branches. You have your superior branch of your oculomotor nerve, and you have the inferior branch of your oculomotor nerve. So superior and inferior. And then next you have some veins. You have your superior ophthalmic vein, and you have your inferior ophthalmic vein. So these 9 structures passes through the little hole of superior orbital fissure and enters exit the skull and come to your orbit. And you have to know these 9 structures, and you have to be able to identify superior orbital fissure for your lab exam. Okay, third nerve palsy or oculomotor nerve palsy, you're gonna see it's on the test. I'm pretty sure of it. And in the question stem, you're gonna see in the question stem like a clinical vignette about a patient that has drooping of the eyelid. That's called ptosis. So the patient comes in with drooping eyelid, and the patient's eye is down, depressed, and abducted. So down and out. And when you look at the pupil, the patient's pupil, it's going to be dilated pupil. It does. He's got lots of pupil constriction, loss of accommodation, and all that is from cranial nerve 3 injury, and maybe the patient had some kind of stroke or something that would cause the lesion on the cranial nerve. And remember, so the patient will lose all the function of cranial nerve. So remember, the cranial nerve 3 innervates the left palpebral superiorlis, so the eyelid. So that's why the patient will have ptosis, the drooping of the eyelid, and also all the ocular muscle that is supplied by cranial nerve 3 will become will not work. So the only muscle will work will be the superior oblique, that's by cranial nerve 4, and the lateral rectus, that's by cranial nerve 6. So those 2 are pulling, those 2 are still contracting. So this one, superior oblique by cranial nerve 4, will depress your eye and move it out. So down and out. And the lateral rectus is still working, still pulling your eye, and that's pulling to the side, that's abducting your eye. So that's why you see the patient's eye depressed and abducted. That's why you see the patient's eye down and out, with ptosis down and out. And also cranial nerve 3 carries parasympathetic fiber, parasympathetic motor fiber, right? And if there's a dysfunction of cranial nerve 3, there'll be no constriction or accommodation of the eye. So that's why the patient will have dilated pupil. So third nerve palsy, you can see ptosis, the eye down and out, and dilated pupil. And of course, the patient's not going to be able to read something close, no accommodation, and also the eyes are not aligned, so the patient's gonna have double vision and trouble walking and seeing and functioning.